Okay, so you're a quarter of the way done with Farm 2. Congratulations. Yes, okay. Again, it'll be mostly the same through here on out, just different subjects. But today we're going to be doing the neurology section. That'll probably be the next 2 lectures, and then we'll do like the headache meds on next Tuesday. So it'll be kind of the first 3 lectures for section 2. So first thing we'll cover with neurology is going to be epilepsy. This is a very brain-stimulating kind of subject, right? That's bad. It's too early. It's too early. It's okay. So seizures we know to be this kind of abnormal behavior. Basically, we're having kind of unchecked kind of discharge of these neurons. Usually some sort of observable phenomenon, usually for a finite period of time, hopefully. Epilepsy is just going to be that kind of categorization of having kind of multiple seizures. It's a collection of many types of epilepsy. I'm not going to get super in depth on specifically different types of seizures, but you'll see in certain circumstances where some meds will be better for one type of seizure versus another, and so we'll kind of hit those as we go along. The nice thing with a lot of these drugs is that they're good for multiple types of seizures, so you don't need to necessarily memorize a lot of differentiation there. Some notable exceptions. And then you have status epilepticus, which is basically just kind of this continuous form of seizures where basically the patient does not get back to their baseline mental status in between seizures, right? So what do you call it when someone's kind of in that kind of altered mental status after a seizure? Yeah, post-ictal states. Never really, get out of that post-ictal state. It's going to go from seizure to post-ictal to back to seizure. So we don't like that because when patients seize, they tend not to breathe very well, and so ischemia can occur, and then that can lead to further seizures, can lead to further issues. So we like to stop that as best we can. So we're going to see there's a specific algorithm and kind of the meds we're going to use to treat status epilepticus versus, say, something like just kind of maintenance therapy for seizures. So there's lots of different things that can cause seizures. Certainly medications can be a big one. I'll show you a bigger list of other ones that can potentially cause seizures in just a second. Mnemonic kind of help to remember what type of drugs can cause seizures, but lots of other things. CNS infection like meningitis can be one cause. Hormonal changes, becoming elderly, different things can certainly cause this to occur. One thing to note here as well, though, that all of your antiepileptics in high enough levels, they can also cause seizures, right? So this is similar to our antiarrhythmics, where all the antiarrhythmics can themselves cause arrhythmias. So very similar thing here. This is why for certain meds, when we're looking at drug levels, they're very useful for telling us, are they in the therapeutic range? Are they achieving efficacy in that they're not having seizures, but also their level's not too high to where they can cause toxicity. And so we'll see what some of those toxicities are, but mainly seizures are one of the big ones you want to avoid. So, as we mentioned, there's kind of this abnormal firing of the neurons that's spreading to eventually produce a full-on seizure. We're going to see that normally that membrane conductance, that electronegativity there, is being left kind of in disarray, essentially. So normally you achieve kind of a nice resting membrane potential. Something is happening to alter that and leads to kind of overexcitability, right? So basically you have some either foci within the brain itself or you have some other kind of predisposing factor to allow it to be kind of hyperexcitable and allow for this proliferation to occur. Some of the main neurotransmitters we're going to be looking at include GABA, which GABA we know is the main inhibitory neurotransmitter, right? And then you have glutamate, which is going to be our main excitatory neurotransmitter. Right? So if you have too much glutamate, what happens? You have a seizure, right? So I see a few people shaking in their chairs here. Could just be the pharmacology lecture doing that. But yeah, so you have too much glutamate, you're going to have a seizure. So how do we combat that? Give more GABA activity, right? So a lot of our medications we're going to see, especially for acute treatment of seizures, are going to be influencing the activity of GABA. We want to make GABA work better because it's a main inhibitory neurotransmitter. Do you actually know how GABA is made? It gets made from glutamate. So there are certain conditions or certain exposures to substances which can actually predispose a person to not really produce a whole lot of GABA from glutamate. Offset puts them in a much more excitatory kind of state and it leads to intractable seizure. So a big one of that would be a TB drug called isoniazid or INH. That leads to inhibition of this glutamic acid decarboxylase, so you can end up having too much glutamate. Certain mushrooms will do this as well. Rocket fuel, hydrogenes can do this. So several conditions which can kind of disrupt this levels, this normal kind of homeostasis between GABA and glutamate. So the way that the electronegativity of these cells are maintained to make sure they're not too hyperexcitable is going to be dependent on this ATP-dependent transporter, right? So we talked about the sodium-potassium ATPase pump before, right? And we talked about it in the myocytes. And normally that's going to be shuttling sodium outside of the cell. It's going to bring potassium into the cell, and this maintains a nice kind of normal electronegativity, right? You guys remember any drugs that inhibited the sodium-potassium ATPase pump for cardiac? Yeah, DIG is the big one that does that there. So if you have some patients who have an issue where they are not that pump is not working as effectively, that can lead things to be more hyperexcitable. That can predispose the patient to seizures. But the big thing here is that it's an active process, right? Because it's pumping things against the concentration gradient in order to maintain a certain resting membrane potential to make sure they don't fire unnecessarily. So a reduced epilepsy threshold, and you'll kind of see when we talk about the seizure threshold, certain things can affect that. Certain things can lower the threshold to where you're more likely to have a seizure. Certain things can raise the threshold to make it less likely to have a seizure. So we'll talk about different medications that can do that. And you also see that there's usually a refractory period. So similar to in the myocytes, there's a refractory period where no matter what kind of signal comes along, it's not going to be able to send another or not trigger another action potential. Same thing happens here, and if you lose that refractory period, that can lead to repeated discharges of the neurons much more quickly than what you would normally see. And again, just a picture here kind of showing the example of how this action potential get propagated down the neuron. And so it's an important electrolyte that allows for this kind of propagation. Sodium is going to be a big one, right? So we're going to see sodium influx is going to be one of the targets for antiepileptics because this is really important for starting that action potential and then propagating along the neuron. So that'll be another target we're going to look at a little bit later. So obviously the diagnosis can be a little difficult in cases when you're kind of working a patient up for a new seizure. Is this a febrile seizure? Is this some sort of organic cause? Perhaps there's a new onset, brain tumor. Perhaps there's some injury that has led to this. Maybe there's medications involved that can lead to these seizures, right? So it's important you get a full history, kind of what precipitated the seizure. Has this happened before? Is there a family history? But get a full medication list, including things like over-the-counter products, herbal products, because you never know what could be influencing this. It could be contributing factor to the seizure actually occurring in the first place. Again, between seizures, you really shouldn't find a whole lot of physical exam findings, right? So that's where things like labs and toxicology screens can be useful. You'll find that, from my perspective, urine drug screens are kind of useless in a lot of cases. I won't get into details on that right now. But other things like MRIs and EEGs can all be useful as well to help you diagnose that patient for why they're having a seizure in the first place. So if you ever were curious, what is a handy mnemonic to remember all the different things that can cause toxin-induced seizures, we have one called Otis Campbell. You'll find toxicologists really like their mnemonics, even when they are way too unwieldy, and no sane person would ever actually remember all of this. But here are some example medications that could potentially cause a seizure. So for instance, why do you think insulin could cause a seizure? All right, the brain needs sugar in order to operate. So if you cause severe hypoglycemia, that could potential cause a seizure, right? Things like salicylate. So aspirin can be a big cause for this in overdose. We talked about tricyclic antidepressants, that being one of the potential side effects we can see with those because they actually antagonize the effects of GABA. And then you have things like your amphetamines and certainly a lot of your ADHD meds. Amphetamine-based ones can certainly cause seizures. You guys know what I mean when I say methylxanthines?
Caffeine and theophylline.
Yeah, caffeine and theophylline can be a big one. So if you have a person who slammed 19 no-dos and a bunch of Red Bulls as a chaser, that could be a potential cause for seizures, right? So you just have, that one's actually due to adenosine antagonism. So by blocking the effects of adenosine, which is normally an inhibitory kind of molecule, you can actually see seizures there. So lots of different things. There's also, as well as withdrawal from certain medications can cause seizures. So ethanol withdrawal can be a big one, right? So what do you call it when someone has kind of severe ethanol withdrawals?
Delirium tremens.
Delirium tremens, or the DTs, right? So that's kind of the very severe form of alcohol withdrawal, which can manifest as seizures, because that can be very difficult to treat seizures. A lot of the cases you will see with these kind of these CNS depressants, especially like benzodiazepines, especially barbiturates, by depressing the CNS, kind of what happens to those receptors over time. If you have like GABA agonists or things that are working to make GABA work better, what kind of happens to those receptors? they downregulate over time, right? So that means when you take those effects away, that means you have less receptors to interact with things like GABA, can predispose you to having seizures because you've kind of lowered that threshold. The cells are going to be more hyperexcitable, and thus you're more likely to see a seizure. So withdrawal can be a very dangerous thing for these patients. That's why you never want to cut off a severe alcoholic cold turkey, because you can see seizures develop. Benzodiazepines are a very similar thing there. So be careful with those kind of drugs, because those withdrawals can be potentially fatal if they are not treated effectively. And then you can see some heavy metals and things like that, so lead, lithium, all those could potentially cause seizures as well. So don't memorize this whole list, just be aware that there is a pretty extensive number of things that can potentially cause seizures, especially from like the toxin/medication side. So don't always pigeonhole patients, try to look for other things that could potentially be contributory here, and find ways to rule those out, right? So a good way to rule out lidocaine toxicity, or lithium toxicity, would be to do what? Do a level, right? So if you have a history of they're on lithium, do a level and find out, what their level is. Lead, you can do levels for lead, so different things like that. Learn how you can rule some of these out. A lot of cases when we're evaluating a patient from like a tox standpoint is to look at their toxidrome, look at their signs and symptoms, right? So someone who came in who had overdosed on an amphetamine would look very different than someone who had overdosed on, say, like a benzodiazepine. So we kind of use those signs and symptoms to help guide us to try to rule things in or out. So more on that when we talk about toxicology later on the semester, but just be aware, lots of things could cause seizures. So what are our goals? Obviously, no seizures would be nice. We'd like no side effects from these medications, but you're going to see that's frequently not going to be possible. So oftentimes we're kind of balancing between efficacy and no seizures versus having not a lot of these side effects. You will see in some cases, especially from my side when I see this at Nemours, is you're going to have some kids who have very severe seizure disorders where their goals may just be to have maybe a few seizures a week, right? You're never going to get them to a point where they're going to have no seizures, because you'd have to get them so high on some of these drug levels that it would be, they need to be intubated basically, right? So some of these kids are just very, very difficult to control. And so you figure out what the goals are going to be, whether there's no seizures whatsoever, which could be attainable in a lot of patients, or just, a few seizures a week, or whatever it happens to be. Address, patient concerns, other comorbidities, and then also just try to help improve their quality of life there. Obviously, seizures can be very detrimental to them, can have lots of kind of psychological effects on them as well. If they're always concerned about being out in public and potentially having a seizure or something, it can be pretty troublesome to them. So address that as well. So other things you want to consider when evaluating patients and trying to start them out on some of these antiepileptics is consider things like their age, right? So age can affect the pharmacokinetics pretty significantly here. So especially when you're looking at something like hepatic metabolism. When we get to the peds section, you're going to see how that changes between, from birth all the way up to kind of adulthood, how hepatic metabolism kind of changes over time and matures. But if you're looking at, in some cases, you may actually have to give kids bigger doses on a milligram per kilogram basis to treat them, because they metabolize certain things more quickly. So for instance, if you're dosing the drug phenytoin, which we'll get into in just a little bit, say from 6 months to 3 years of age, they need 8 to 10 milligrams per kilogram per day to achieve kind of maintenance doses, right? To achieve good blood levels to prevent seizures. Versus, you almost use, almost half of that as a fully grown adult, right? So if I were to give that, adult kind of normal dose to a child, say someone who's 2 years old, they would be more likely to have more seizures because they're not being dosed aggressively enough, right? So keep that in mind. That's why when you look up the different dosing regimens on your handy dandy drug references, like that's why they have those differences there, is based on things like functional maturity of organs. Look at other medical conditions. Certainly, if things can affect, if they have pre-existing liver disease, maybe that's not a good option for certain drugs. Maybe you want to use certain things that are going to be more renally eliminated. So consider things like that. Look at their ability to comply with the medical regimen. So for instance, if they have to take a drug, 4 times a day, that may not be super great for them. Maybe something like a delayed release option is going to be better, or some sort of sustained release type product. So look at their ability to comply with this, especially when you're looking at pediatric patients. That can be very difficult, especially if you're trying to give them medications that may not taste very good. So you have to think about things like palatability and whatnot. So consider that, and then insurance coverage. So a lot of these, some of these drugs are going to be newer agents that may be very effective, but they may not be covered by the patient's insurance. So obviously, if they can't pay for the drug, they're not going to take it. So that's another thing to consider as well. So when you're assessing a seizure, obviously you want to figure out, one, did a seizure actually occur, or maybe there's something else that was going on in the first place. If it did, then you kind of try to deduce what type of seizure it is. Again, I'm not going to get super into detail on the differences between the seizures. Have you guys covered anything on epilepsy yet? You'll get into that. You'll get into all the different subtypes of seizures and whatnot. I see a lot of absent seizures happening, usually around 8 o'clock in the morning or so in this classroom. So you guys might want to get that checked out, just a thought. And then, once you kind of figure out, say, okay, well, I kind of figure out what type of seizure this is, you want to determine whether or not you want to do pharmacotherapy, right? So for instance, if you had a kid who had a febrile seizure, or a seizure that is related directly to their hyperthermia, do you think you need kind of long-term seizure management for that? Probably not, because there's kind of a reversible cause, right? You need to look at things like, is this a reversible cause? Is this just a temporary condition that led them to have seizures? If they had meningitis and developed seizures, they're probably not going to have that long term, right? So consider whether or not you need actual pharmacotherapy in those cases. And then we'll look at which drugs may be most appropriate for them. And then the monitoring comes in. The monitoring is going to be very, very important for a lot of these drugs. Monitoring for drug interactions, monitoring drug levels, looking at CBCs, looking at LFTs. All of those are going to be really important for specific drugs. And so we'll talk about what those are in just a little bit. But keep that in mind that monitoring is very important here. So for the most part, you're going to see that the majority of patients are going to be well controlled with just monotherapy. So about 65% of patients can get away with just using one drug. You're going to see that some patients, a subset of those will need kind of dual therapy. And then you're going to have some patients, about 20% or so, that are just never going to be really well controlled. Right, those are those patients that are on 4 or 5 different meds and still are having 4 or 5 seizures a day. Right, so you can sometimes see those kids that are very, very tough to treat like that. Adult patients are like that as well. There are other things you can do than just pharmacotherapy. So things like vagal nerve stimulators can be useful. Surgery. You guys ever heard of a ketogenic diet? What is that? You guys have heard Atkins a lot. So yeah, so it's kind of like an extreme form of an Atkins diet where you're going extremely low carbohydrate. Basically, having no sugar, no carbohydrates whatsoever puts you in a state of ketosis, right? So what does that do to the blood pH? Should go down, right? Should make you more acidic, right? So you're producing a lot more ketones and things like that are making the blood more acidic. Actually, when you make the blood more acidic, that will raise your seizure threshold, which makes it less likely for a person to seize, okay? So you'll have some patients who will come in, and sometimes recognizing those patients can be difficult, especially like say you're working in an ER, kid comes in, they don't necessarily state they're a ketogenic patient. Like that can be problematic because you might give them medications that can mess up with that, right? So sometimes you'll see, like in medical records, you'll see that they have a dextrose allergy. Sometimes that's one way to kind of denote that, hey, don't give them any kind of sugar. You'll screw up their ketogenic diet. The other thing to consider is that there's a lot of medications that have sugar in it. Right, so what kind of IV fluids would have sugar in it? Dextrose, right? So giving them dextrose or giving them carbohydrates would put them out of ketosis, right? A lot of medications, especially for kids, come in suspensions. Sugar is involved in a lot of those as well. So you have to be very careful what kind of medications you give them. A lot of times for kids like this, you have to use the regular tablets and then crush them up and suspend them in water and administer it that way, right? So that way they're not getting excess sugar from their medications, because they have to count every single carbohydrate they're intaking and make sure that they do not exceed a certain limit. So it's important to consider that. We actually had one patient who's coming in. She had a seizure history, but she's actually coming in for a pneumonia. And end up kind of having kind of a SIRS kind of septic shock kind of looking pattern as she was kind of developing in the ED. So she's already getting hypotensive. They want to treat her for the pneumonia. So patient comes in, they're looking really sick like that. What kind of drugs do you think you want to use for the pneumonia? So we want to do broad spectrum antibiotic coverage. So I heard Vanco, right? So that's going to cover what kind of bugs? Our gram-positives, right? Good. And what else do we want to use? So we need something for our gram-negatives. Fluoroquinolone could be one option.
How old is she?
She was like 15.
Clindamycin.
Clindamycin, that's going to be more gram-positives and anaerobes. So like ceftriaxone's a good option, right? So that's going to be good broad spectrum, 3rd generation cephalosporin. It's not going to get Pseudomonas, but we weren't really concerned about Pseudomonas for her. Really, her only history was seizures. So vancomycin, if you don't know it, when you order it frequently comes in dextrose. So that was one thing where we had to figure out, okay, Maybe we don't need, and so on her history, she had a history of ketogenic diet. So, and then we also wanted to put her on a pressor, which norepinephrine is the thing we ended up going with, and that is frequently put in dextrose as well. So, of course, as soon as I saw that, I was like, hold on, let's figure this out. So I went to mom. Unfortunately, the kid had been taken off the ketogenic diet. They didn't really need it any further, but it was still on the record. So it was one of those things that was kind of confounding us until we kind of got a better history, and we said, okay, well, giving her dextrose is going to be fine. But that is a potential kind of roadblock you can run into to making sure the patient does not get too much sugar. Okay. So not something done super frequently, but something you can see used every once in a while. And you guys ever heard of Charlotte's Web? Yeah, what is that? It's medical marijuana, right? But it was a strain that was actually legal before the newer medical marijuana law. And that one was high in a product called cannabidiol, right? So that was had very low THC in that strain. The cannabidiol was another thing they were trying to use for seizures. So sometimes they'll use that for more refractory patients as well. So lots of different options here. Pharmacotherapy is not always going to be the best option, but it is for a majority of patients. So again, when we're determining our optimal seizure therapy, to look at the seizure type and the frequency that's occurring. So when we talk about certain things like absence seizures, like you're going to see certain meds are going to be better for that than others. But again, like I said, most of the drugs we're going to run into are kind of multi-purpose. They'll treat lots of different types of seizures. Look at the patient goals. So again, do they want to be seizure-free? Do they want to have, a few side effects? Kind of look at those things. Drug interactions are going to be super, super important here. So some of these drugs are CYP inducers, some of them are CYP inhibitors. So it's important to keep that straight. So when you run your interaction checker, you can be aware of all that stuff and adjust their doses appropriately, right? Especially if they have other comorbid conditions that you need to be treating as well. We'll look at their adverse effects. The mechanism can be important, especially when you're using kind of multiple modalities of therapy, because you want to use things that have synergistic mechanisms together or complementary mechanisms. I don't want to use multiple sodium channel blockers because I'm not going to get any extra benefit out of that. I want to use maybe something that enhances GABA and then one drug that blocks sodium. So we'll see as we get through the mechanisms how those can be complementary. Look at monitoring, follow-up goals, and then obviously compliance and costs are going to be the biggest things. So make sure that you have a regimen that they can be compliant with and they can pay for. So again, monotherapy should be used most often, especially for kind of chronic maintenance of these seizures. And then for those who do not achieve adequate control, that's when you can consider adding on a second drug. If they failed kind of multiple therapies, that's when you need to start considering other options. So whether it be surgery or ketogenic diets, things like that. So again, they failed kind of multiple different drug therapies, and that's when you can start to move on to other things. Generally with these drugs, you want to start low and go slow. Obviously, you want to make sure they're not having seizures, but you'll see that the side effects are present with almost all these drugs. And you want to, you can always give a little more. You can't necessarily take it back, right? So start low, go slow with these guys, and then just watch their response to treatment. See how they're doing. Make sure they're keeping, a diary of when they have seizures, what kind of effects are happening there. And keep in mind that some of these are going to need therapeutic drug monitoring. You guys remember what that is? What is that? Look at the blood levels of the drugs, make sure they're within a certain range. So I'm not going to ask you guys to memorize the ranges for the drugs, but I may ask you guys to interpret those levels, right? So like I mentioned last time, a patient comes in, they're having no side effects, seizure-free, and the level comes back high. Probably don't need to do anything with it. And you'll be able to make kind of assessments like that. And then, as I mentioned, whenever you're switching or using different drugs together, make sure to use different mechanisms. Yes? Typically, you're giving it at least probably a month or two, at least. Sometimes these drugs are effective. It's not like antidepressants where it takes like 6 weeks for them to really kick in. They're going to be effective pretty much as soon as they get to kind of a steady state level, right? But you need to assess for things like kind of more long-term side effects. Like some of these things may not kind of manifest all their side effects right off the bat. It may take time for them to kind of develop. So give them time, see how their seizures are. Have they decreased? Have they increased? Have they not changed at all? Maybe you need to adjust your dose some. Maybe you need to do whatever. And then you're looking at side effects as well. So you need to give it some time to work. Yeah. Okay. So the main groups of drugs we're going to be focusing on, we'll see we have some sodium channel blockers. We'll have some calcium current inhibitors or other kind of calcium channel blockers. Some things that will enhance the activity of GABA. And then we'll see things that will block glutamate. And then there's some kind of other kind of miscellaneous drugs. So again, carbonic and anhydrase inhibitors used to be used a long time ago for seizure management. Those actually cause a hyperchloremic or non-GAP acidosis. So again, that was the thing where we're kind of lowering the serum pH in order to help increase that threshold for seizures. Hormones can have an effect here as well, and then there's going to be some drugs where we don't really know how they work. They seem to work, but we don't really know why. So some of our targets. So when looking at the first thing we mentioned that how those action potentials get propagated is through sodium influx in these neurons, right? So this is very similar to what you see with some of those antiarrhythmics, especially working for cells that did not have any automaticity to them. It was all related to sodium influx. Once they got to a certain threshold, they open up those sodium channels, sodium flows in, increases the electronegativity of the cell, and they have an action potential, right? So same thing's happening here. You'll see that, again, there's going to be several channels or different states for the sodium channel. I'm not going to get super in depth on which ones block the resting versus active or inactive. Not super important to our purposes. Just know whether a drug is a sodium channel blocker or not. Right, so that'll be the kind of the extent of what I'm asking you guys. But again, notice how you'll have that big kind of spike in the when you had the action potential. You had that repolarization of the cell, and then what's kind of maintaining this resting potential here? What? Yeah, that sodium potassium ATPase pump, right? So this is that thing where it's bringing sodium, putting that outside of the cell, potassium's coming in, and that's helping to kind of reset that resting potential, right? So if this is getting goofed up here for whatever reason, whether it be from a genetic reason or otherwise, that can change this resting membrane potential point, and if it raises it, that's going to make it more likely to fire off and have an action potential. So that's why those patients may be more likely to have a seizure in those cases.
So then for the ketogenic diet, if you're increasing, if you're decreasing the pH, how is it supposed to increase the threshold level?
For whatever reason, it just makes it less likely for those action potentials to occur. I don't know the specific mechanism, but doesn't really, not that I know of, that it really affects that. It just makes it, when you put yourself in a more acidic state, because you can see things like, protein structure changes based on pH, right? So for instance, when you have a septic patient who's really acidotic, like things like catecholamines don't like to bind to adrenergic receptor. So it could be related to things like that, but just in general, as you get more acidotic, that seizure threshold tends to increase. And this is kind of a mild acidosis. It's not like, your pH is 7.1 and they're like going septic or something. Just kind of a mild acidosis you induce here. So just some examples of how the drugs can specifically work to block the channels. You're going to see that many drugs fall in this category, especially some of the older ones we're going to be talking about, so things like carbamazepine, phenytoin. But basically by preventing sodium channel influx, you prevent the action potential from recurring. Okay, so no action potential, no propagation of the seizure. We'll see that we know of lots of different types of calcium channels here. The antiepileptics we're going to be using for seizure specifically are going to be blocking the T-type calcium channels. You guys remember which kind work for cardiovascular uses? It's the big L, right? So it's the L-type calcium channels are the big ones we use there to work on the heart and to work on the blood vessels, so your dihydropyridines and whatnot. But here we're using actual T-type calcium channels to block influx of calcium. So we know calcium will go into the cell, raise the electronegativity, can lead to more seizures. So we'll have some drugs that will specifically block that. So again, one of the big ones we'll talk about here specifically is going to be ethosuximide. That's going to be really important when we talk about absence seizures. So this is not like a major target for lots of antiepileptics. You'll notice Valproic is going to pop up on several different kind of targets. So valproic acid is going to be a good one that kind of works on several different mechanisms. Where else did we see valproic acid being used?
Mood stabilizer?
Yeah, it's a mood stabilizer for bipolar disorder, right? So this is where you see a lot of these drugs where they got their initial start as an antiepileptic and they get kind of secondary uses for other kind of behavioral conditions. So next we're going to look at the GABA receptor. So there's two different types of GABA channels. There's GABA A and GABA B. Do you guys remember which ones like the skeletal muscle relaxants work on? GABA B, right? So GABA B are more for like kind of the skeletal muscle relaxants. GABA A is going to be more important for uses for seizures and epilepsy. So essentially, they work the same though. So when you have GABA come along and bind to the GABA receptor, you're going to open that channel up. It's going to allow what to flow in? Right, GABA is inhibitory, so we want to make that cell more hyperpolarized and more difficult for it to fire. Chloride. Chloride is going to flow in, right? So we want a negative ion to flow in, so that way it's going to make the more electronegative to make it more difficult to initiate an action potential, right? So we're going to allow a negative ion to flow in. So chloride's going to be the big one here. As I mentioned, there's GABA A and GABA B, but GABA B is going to be more related to things like potassium channels and whatnot. But we're going to see that the GABA A is specifically for chloride inductance into the cell. So there's a couple different ways you can affect GABA within the body. So it's not only specifically making GABA bind to that receptor more easily, like we saw with the benzodiazepines, or specifically drugs that may open up the channel, like barbiturates. We can do other things to influence either GABA metabolism or how it's being handled within the CNS. So for instance, by changing the activity of glutamic acid decarboxylase, which is important for converting glutamate over into GABA, you can increase the amount of GABA available to be released from the neurons. So that can be one useful thing. So for increasing the amount of GABA being produced, that can be useful. You can also do things, certain drugs will block the reuptake of GABA. So similar to what you saw with like the serotonin reuptake inhibitors, similar things happening here with GABA. So you'll see tiagabine being one of the drugs that can do this. You can also inhibit GABA metabolism. So you can inhibit the enzyme GABA transaminase, which normally breaks down GABA. Inhibiting that would also increase levels. So again, that would make it work more effectively. And then you can also have drugs that will bind to different sites on the channel that will allow GABA to work better. So that's when our benzodiazepines and our barbiturates are going to come into play there. Okay, so that's one of those. When we were treating acute seizures, this is the main way we're going to be treating these. So benzodiazepines are going to be really important for doing acute seizures, as we see going forward. So again, just a few different sites here where you can see GABA specifically working. So again, benzodiazepines, what you actually see with the GABA channels, they're made up of these different subunits. And so you'll see that when different sites in the CNS, you're going to have different subunit makeups of these GABA channels. But specifically, there's a site where the benzodiazepines can bind here to the GABA channel and will allow the GABA to bind more easily, right? So it affects how easily the GABA can bind to the receptor and will open this up more frequently, right? So that's how it can help to increase chloride inductance and make that cell more difficult to have an action potential. Here you can see where you have like the glutamic acid transporter, right, is important here, affecting things like GABA transaminase and the glutamic acid decarboxylase. All those are going to be very important for changing how the GABA is handled to increase levels, essentially. So we're just making GABA work better through a couple of different mechanisms. And one of the few, the last ones we'll look into is going to be glutamate as far as another neurotransmitter here. We don't have a lot of drugs that specifically antagonize the effects of glutamate as this kind of main mechanism of action, but just be aware that excess glutamate activity is going to lead us to have more seizures, right? So we're going to block that if we can. Normally, glutamate will cause inward flow. Things like sodium will make the cell more likely to have an action potential. So again, these are going to make it more hyperexcitable, more likely to have an action potential. There's lots of different glutamate sites. Some of the big ones include like the AMPA site. There's the NMDA site. That's where drugs like ketamine, things like that will work specifically. Not an antiepileptic, but just as a kind of a preview for things to come. So glutamate's important for things like anesthetics and certain types of analgesia. But for seizures, normally it's going to be the AMPA and NMDA site that we're really looking at as far as blocking those effects to prevent seizures. So things like felbamate and levetiracetam can have some activities here blocking NMDA. Things like topiramate or Topamax can be useful at blocking the AMPA kinase. I'm not going to get specific and ask you which type of glutamate receptor these guys are blocking. Just be aware that they can have some activity there to antagonize the effects of glutamate, which will lead you to have less seizures. So, and again, different channels are going to have different activities. So some will allow sodium to flow in, some are going to be affecting calcium. So different activities, but just be aware all of them are going to lead the cell to be more hyperexcitable. Okay, so a few other kind of miscellaneous targets here. So we can have certain hormones play a role in seizure development. So things like progesterone and estrogen can actually have a role in either preventing seizures. So progesterone can be actually preventative, and estrogen can be more seizure-inducing. Again, there's no therapeutic roles right now. So if a patient has an acute seizure, I'm not going to give them a birth control pack and say that doesn't really work that way. And then when you look at the carbonic and anhydrase inhibitors, these are older antiepileptics. This is before we had a lot of the kind of the more modern drugs we have nowadays. But certain things like, do you guys remember any Carbonic anhydrase inhibitors? Diamox or acetazolamide would probably be one of the big ones there. So that's kind of the most common one you're going to run into, at least for oral therapy. Remember, there's also some we use for glaucoma, like brinzolamide or dorzolamide. So those induce kind of a mild acidosis, which can increase your seizure threshold. So that's another thing you may see used occasionally. Where else do you see acetazolamide being used? So glaucoma potentially. Where else? What else do we talk about its use? So it's a diuretic. Remember, acetazolamide can be a diuretic, and then also sometimes use it for altitude sickness. So you can actually use that to actually help prevent, say if you're going to go to Denver for a week or two, you can actually take that beforehand to prevent some of the altitude sickness you get there. So several uses for acetazolamide. Okay, so getting into the specific drugs, the first one we're going to talk about is going to be phenytoin or Dilantin. This one is specifically working by blocking sodium channels to prevent sodium influx, and thus hyperpolarize those cells and prevent them from having action potential. This drug is highly protein bound, around 90%, and that's going to be important when we talk about our drug levels in just a few slides. So keep that in mind. They also undergo this kind of goofy kinetics called Michaelis-Menten kinetics. So do you guys remember first order and zero order metabolism? Reach all the way back to pharmacodynamics. Anyone remember that? So majority of drugs, do you think they undergo zero order or first order kinetics? I heard first order, so there's probably some tickling of a recollection of these concepts there. Yeah, so a lot of drugs undergo first order kinetics, which basically means you're metabolizing a certain percentage of drug per unit of time. So say 10% of the drug per hour, okay? So that means every hour you're metabolizing 10% of whatever drugs in the system, right? So as I have higher levels, 10% of that is going to be a lot more than if I have a lot lower level of the drug, right? So that's why you have this kind of proportional increase in metabolism as the levels get higher. With zero order kinetics, what do you think that is?
Constant amount.
Yeah, so the same amount of drug is metabolized per unit of time, right? So ethanol is probably the big one there, where ethanol is metabolized at, say, a constant 20 milligrams per deciliter per hour, right, as an average. So so even though your levels may increase to, say, 400 or 500, to be way too drunk, you're still going to metabolize the same amount of alcohol per unit at a time, right? So the problem with that is that metabolism really starts to slow down as you go from first to zero order kinetics, right? So in some cases, this can be problematic. So especially with phenytoin, this is an issue. So you'll see that the dosing has to be you have to be kind of careful with the dosing of phenytoin, because if you bump this up too much and you saturate those enzymes within the liver, they can switch over to zero order kinetics and they can have a hard time metabolizing the extra drug off, and you're going to see more toxicity. So for instance, we had a patient who was in the emergency department who was coming in for a seizure. She had a known seizure history, but she'd run out of her meds. This is an adult ED. Run out of her meds and hadn't been on it for a while, so she came in. Normally takes phenytoin, so they said, okay, let's load you up with a bolus of phenytoin, right? So we give a loading dose to get her back up to a good level, right? Well, the first resident did that, and then they had change of shift. And then no one documented the first dose being given. So the second resident came on. You just had a seizure. Let's go ahead and give you a loading dose. Patient ended up getting 2 loading doses, right? So now our levels were pretty much double of what they should have been. Okay, now the patient's having ataxia, they're having really bad nystagmus, they're a big fall risk, they're feeling really crummy all of a sudden. So she ended up having a switch over from first order to zero order kinetics, and it probably ended up taking 4 or 5 days in order for it to actually metabolize the drug down back to a normal therapeutic level. Okay, so be careful with phenytoin because of those changes in kinetics. If you increase the dose too much, you risk switching over into that zero order kinetics and seeing toxicity there. Okay.
So normally it's being metabolized by percentage, and then there's just like a max where it can't do percentage anymore, and then it hits a max amount.
Yeah, and so imagine like factory workers or something. Like you only have 10 workers. You're right. Normally they're processing say 5 boxes an hour. They can keep working that. Or if you increase it to 7 boxes, they can do that too. Once you get to 12 boxes, now you've exhausted your available workers, and now it's going to slow down pretty much considerably slow down. Right, so you've kind of exhausted all of those enzymes. They're busy metabolizing the drug as it is, but they can't really metabolize anything more. Okay, most drugs do not go into this, or you don't get levels high enough to actually go into these kind of saturable kinetics, but phenytoin is one of those ones where it's very easily to hit that level. Okay, and it'll be a little different for every patient, so just be aware of that. It's also metabolized by several CYP enzymes, so like 2C9, 2C19. These are important, especially when you're talking about things like warfarin metabolism. So this comes up again and again. And specifically, phenytoin can induce 3A4. So that can be a big source of drug interactions. It can affect the 2C families as well, along with that protein or P-glycoprotein, or PGP, right? So it can induce all of these. So for instance, if I had, say, something like simvastatin on board, what could phenytoin do to my simvastatin levels? This is a CYP3A4 inducer. It would decrease levels, right? So maybe make my statin work less effectively because my blood levels would be going down more quickly. So keep that in mind. There are several different dosage forms that are available for phenytoin, and so you're going to see that the absorption is going to change based on that. So obviously, if you have an immediate release type product, you have kind of earlier peaks and a lot higher peaks than if you had an extended release product. So a lot of patients end up getting put on extended release products, so that way they have kind of a nice kind of plateau effect. They don't really see big peaks in levels, and you don't really run into any issues with kind of increased toxicity from that. These are really good for all types of seizures. So this is kind of an all-purpose seizure treater, if you will. Generalized partial seizures, they'll work for all of it. They don't really work for absent seizures, and we're going to talk about a specific method that's going to work for that as we go on. But just be aware that you can use this for lots of different things. You're going to see that the side effects are going to be pretty consistent for the most part with a lot of these antiepileptics, right? So by slowing down the CNS, by inhibiting and making these neurons more difficult to have an action potential, what do you think that manifests as far as side effects go? So I'm keeping your neurons from not firing as quickly. So imagine like you're 8 o'clock in pharm class, your neurons are not firing off very quickly right now. Lethargy, see ataxia, nystagmus, they're a big fallers. This is very consistent with a lot of these drugs, right? Because you're slowing down the CNS, so that CNS depression is going to be consistent with almost all of these drugs. So again, this is kind of a class effect. You're going to see this with many of the drugs. We'll talk about specific side effects that may be associated with 1 or 2 of these drugs, so kind of key in on those, but just be aware that any antiepileptic at high enough levels is going to slow down the CNS and lead to CNS depression, okay? Other things you can see with phenytoin is some hirsutism, so that can be problematic for some young ladies, and you also can see gingival hyperplasia. That's kind of a common ADR you see with more chronic dosing, or you see just kind of the gingiva start to kind of overtake the teeth some. So then it could be a potential cause for discontinuation if you end up seeing that. You can give this drug IV, but the drug itself does not like to go into solution very well. It actually has to be kept at a pH of like 11, which is pretty high. Has to be mixed with things like ethanol and propylene glycol and all kinds of other stuff to get it into solution. So the big problem with phenytoin, if you extravasate the drug, right? So if you inject it outside of the vein, it can cause a lot of tissue necrosis and cause what we call the purple glove syndrome. Have you guys heard of this? Essentially, the drug will get extravasated out, will start to necrose the tissue, and it kind of looks like a purple glove, basically. Can cause gangrene, has been seen to cause amputations in some cases, so it can be very, very significant. This is why we do not like to give phenytoin IV, but if you have to do it in as deep a vein as possible. Make sure you have really good line placement beforehand, because you do not want to have extravasation of this drug. Really problematic. But sometimes you have to use it. So for instance, there's another variety. We like to use the Fosphenytoin, which is a more water-soluble form of the drug. We like to use that, but we actually had a shortage, or they had a recall on the drug because there were some issues with the vials they put the Fosphenytoin in. So we had to use phenytoin. And if you can imagine, for an adult patient, they have pretty decent-sized veins, but if you're dealing with, say, a 2-year-old, how big are their veins comparatively? Pretty small. Pretty hard to get an IV. A lot of those end up blowing. So this is very kind of problematic, and we didn't really want to use phenytoin for a lot of those patients unless they had something like a central line. That way we could ensure there's no going to be extravasation. So that's kind of one of the clinical kind of issues we ran into due to drug shortages and things like that. So the Fosphenytoin is basically just phenytoin with a phosphate group added on. This increases its water solubility considerably, which means that you can give Fosphenytoin intramuscularly. You can give it IV with a lot more ease. You don't see as much kind of thrombophlebitis or extravasation risk. So it's kind of the preferred go-to IV form of this, but just be aware that things like shortages and recalls can occur that may lead you to use phenytoin instead. Also, other things you can potentially see are going to be rash. Stevens-Johnson's are going to be a potential here as well. So again, educate them on, new onset rashes, blisters, things like that, to be kind of concerned with those. And you'll see that these are kind of first line therapy for generalized and partial seizures. It's an older drug, but it's still kind of a standard go-to in a lot of cases. So we're going to see this pop up in our status epilepticus management as well when we get to that point. So here, this is just kind of recap that zero order versus first order kinetics we talked about. So again, with first order kinetics, it's nice because you metabolize, as the drug levels get higher, you metabolize a higher amount of drug per unit of time. But once you hit that zero order, it takes forever for these drug levels to come down, right? So just be aware of that you have to be very careful with the dosing here. If you bump it up too much, you're going to see this zero order kinetics take over. So don't memorize the dosing here, but just be aware of the changes in dosing, as I mentioned, between adults and kids. That's going to definitely change. And normally we give these patients a loading dose, so that can be done either orally or IV. Frequently, like in the ED, you see IV being given, but you give a loading dose because that lets you reach what more quickly? Yeah, so you're already at steady state, and then you can start maintenance dosing because the drug has a fairly long half-life, so it takes time to really get to that steady state, and we want to treat their seizures right now, right? So getting to steady state is going to be the best thing for us, and that allows us to get to our therapeutic range, right? So normally, we will measure a total phenytoin level, and basically that means we just collect a sample of blood, you test all the phenytoin in that blood to see what the level is. Normally, a therapeutic range is between 10 to 20 micrograms per ml, okay? Now I mentioned the drug is highly protein bound, which means about 10% of it is unbound, which means how much of it is pharmacologically active? 10% of it is unbound and is pharmacologically active, because that's what's available to interact with the receptors. So that means that a free phenytoin level, if you have 10% of that that's free, should be 10% of the total level, or 1 to 2, right? So in some cases where you get a patient who has a level of, say, 15, but they're having toxicity or they're having breakthrough seizures, the next thing you should ask yourself is, what's the free level? Check a free level, because you're going to see that there's going to be some issues where different conditions can actually change that proportion of free drug and can really screw up your levels. So I'll show you some examples of that in just a minute. So biggest things that can affect the protein binding here is going to be your albumin stores. So if you have a low amount of albumin, which is the primary protein that phenytoin is binding to, what do you think that does to the free fraction drug? Goes up or down? Should go up, right? Because there's less protein sites for it to bind to, so it goes up, which means that you may have, say, a total level of 15, but now your free level's gone to 3, right? Which is outside of that therapeutic range now. So say you had a patient came in, was having ataxia, nystagmus, they're like, oh, I just don't know what's going on, I just feel terrible. Check a level and it's 15. Check that free level. And, if they had poor albumin stores, if it was due to malnutrition, sometimes critical care patients can manifest with this, or they have renal failure. That can all lead to the free levels being higher than what you would expect, and can explain a lot of that toxicity. Okay, so again, always treat the patient, not the number, but be aware that you can check a free level of phenytoin, and that can give you a lot better clues of what's actually active in the patient's body.
Is the free level, like, I know that you do therapy and monitoring in the hospital and all that. Is the assay for free phenytoin or any of these drugs readily available to you?
The free level for phenytoin is really the only one you're going to see used clinically, and that is pretty widely available. I've never been to an institution where that was not available, or it could be a send-off in some cases if you're working at a smaller institution, but that could still be useful, right? So you can still send that off, may come back in 2 or 3 days, but may give you better clues of what's going on with your patient. So just be aware of that. If things don't make sense based on what their levels are and based on what they're showing you, see if there's something else going on, right? And so in this case, you can always check a free level to determine that in this case. Just be aware there's lots of different formulations here. Again, don't memorize anything off the slides specifically, but just be aware that you have different salt forms which can change the active amount of drug in there. One of the things we run into, and again with kids, what type of dosage form are we frequently using? Suspension, right? So we said suspensions are, is it kind of this nice kind of homogeneous mixture where it always stays in solution? No, what happens to suspensions if you let them sit for a while? Settles down at the bottom, right? So what do you need to tell patients to do with it? Shake it up real good, right? So there's been cases where moms will come in, they're like, man, my kid's having, they bring a kid to the ED, they're looking, like they're drunk practically. They're like, I don't know what's going on. Like, early on in the month, the kid's having seizures, all these breakthrough seizures, and then all of a sudden I gave him a dose and he's acting like this. He's stumbling around, running into stuff. You check a level and sure enough it's high, right? Patients sometimes will not shake up the bottle well enough, and so they get basically the patients get no drug throughout the month, and then they get to the very end of it where it's all drug, and they get the levels way too high. So again, think about things like that, about what the dosage form is and if they're using it appropriately, because that can give you a big clue as to what's going on. Now, Fosphenytoin to Phenytoin, if you look at a Fosphenytoin vial, you're going to see its dose being shown as PE. If you ever see that, it basically just stands for phenytoin equivalents. They don't make you do the conversion because, again, Fosphenytoin being a larger molecule than phenytoin, the actual milligram amount actually changes a little bit. But they do this conversion for you. So essentially 50 milligrams PE of Fosphenytoin equals 50 milligrams of just regular phenytoin. So don't be worried about those conversions. The dosing is the same between the two drugs. Really, just the big difference is that phenytoin, the phosphate group has to be cleaved off of it to get the parent drug once it's injected into the body, so for it to actually be effective. So, again, just kind of reiterate these points here. When the parenteral phenytoin is being given, you cannot give that IM because of the high pH and cause necrosis, so you don't want to do that. And you don't want to inject it too quickly, right? So, and frequently in adults, like you can only give it, say, 50 milligrams a minute. And say if you're giving a full 1,000 milligrams, that can take time, right? It takes probably about 20 minutes in order to get that full dose in. If your patient's actively seizing, it's not really such a good thing, right? That's one of the problems with it. If you give it too quickly, you can also see cardiac depression, so you can see bradycardia, dysrhythmia, because again, blocking sodium channels, it's not exclusively just doing it to the brain, you can also do it to the heart if the levels get very high very quickly, so that's why you don't want to give it too quickly. Actually, phenytoin used to be originally discovered as an antiarrhythmic. Realized it wasn't a very good drug for that. Instead, used as an antiepileptic. So you can't see those cardiovascular complications by giving the drug too quick. With the Fosphenytoin, it's nice because you don't see as much phlebitis, it's more water soluble, and you can also give it about 3 times as fast. So I can push 150 milligrams a minute versus just 50. So just be aware of some differences there between the two drugs and how those are going to be administered. Any questions from the first half? All right, so moving on, we have carbamazepine or Tegretol. We've talked about this already in bipolar disorder, right? Yep. Okay, we talked about there. All right, so same thing here. Sodium channel blockade. Big thing to note: it induces its own metabolism. So, what does that mean with the dosing?
You gotta do it higher than you'd expect because it's constantly.
Yeah, so you'll see the dosage regimen is going to go up steadily as you start off at the starter dose, and then you kind of go up as that metabolism starts to increase of its own. So this is also going to be a big CYP inducer that's important for drug interaction purposes, right? So this one gets metabolized by CYP3A4. It also has an active metabolite that can have some activity here as well, which may help it to have kind of a more kind of prolonged seizure blocking kind of effect. This will induce CYP3A4, 2C9, 2C19, so lots of drug interactions, right? Lower those levels of things like warfarin, your statins, things like that. Very similar side effects to what you see with phenytoin in regard to kind of the more of those minor like dizziness and diplopia and things like that, as you can see, just due to that kind of CNS depression or making those cells more or less hyperexcitable, right? You may see some increase in LFTs in some patients, so you do want to monitor that. Usually at baseline, monitor the LFTs and kind of see how that changes, month 1 or month 3, something like that. And then you can see some minor bone marrow suppression. So it'd be another thing you want to be looking at, kind of baseline and then follow-up CBCs, looking for things like thrombocytopenia, leukopenia, and whatnot. The other one thing to note here is the electrolyte changes you can see, so hyponatremia is possible. Do you guys remember why that happens? Is the SIADH, or that syndrome of inappropriate antidiuretic hormone, right? So essentially you're releasing too much antidiuretic hormone, you're holding on to too much, you have too much antidiuretic hormone is going to lead to too much water retention, and that leads to kind of a dilution of your sodium. So we can see that there. So looking at the dose, again, don't memorize the dosing, just notice that how it is going to increase as time goes on in order to account for that autoinduction, right? Because what would happen if I started the patient directly off at 15 mg per kilo per day? Right, so if I started at the kind of week 4 dose, I'd see more likely to see toxicity, right? Because they're not metabolizing it that quickly yet. It takes time for those enzymes to autoinduce. So that's why that increases there, and we don't just start them off at the kind of the final dose. Notice here, there's also a therapeutic range that we use. This is only a total level. There's no free levels of carbamazepine we get, but say 4 to 12 is our typical. As you start to get above that, you start to see obviously more side effects. Above 20 is where you can start to see more things like seizures start to develop. You can see some things like QRS prolongation, some cardiac dysrhythmia. So again, keep the levels within range as best you can, and hopefully the patients will tolerate that. Kind of a congener or a drug that's similar to carbamazepine is going to be oxcarbazepine, sometimes used for bipolar disorder, not super frequently. While it is structurally related to carbamazepine, can I get a carbamazepine level to measure oxcarbazepine? No, they're not that similar, so you cannot get levels for oxcarbazepine readily. Fewer adverse drug reactions and also drug interactions than carbamazepine, so there's no CYP induction here, which is nice. So that kind of helps limit a lot of the drug interactions. And you'll see very similar efficacy to carbamazepine. The only thing you have more of with oxcarbazepine than carbamazepine is going to be the hyponatremia. So this actually occurs more frequently. But for some patients, it may be a better option than carbamazepine, especially due to drug interactions. Next, a very common one that is used, especially in bipolar disorder, but we use it frequently in seizures, is going to be valproic acid. Lots of different brand names here. You have like Depakote, Depakon, Depakine, all kinds of different ones. But here, this one starts to get into kind of multiple mechanisms. It can block some sodium channels. It'll block some calcium channels as well. And it also helps to enhance the availability and the actions of GABA. So several mechanisms here. Probably why it's pretty effective for seizures. It's good for that. It does have some saturable protein binding, which means that as the levels start to climb higher and higher, you can actually see a higher free fraction of drug, which can lead to some of that toxicity. Normally, patients are not getting that high of a level, but that becomes more important when you start to see like overdoses and things like that. But just be aware that normally it's about 90% protein bound, but you can saturate that at a point and can see more toxicity after that, just because that free fraction increases pretty significantly. As mentioned, there's different dosage forms, so there's delayed release capsules, there's liquid formulations, all kinds of different things, and so their characteristics are going to be a little bit different between them, but just be aware of that when you're kind of converting patients from, say, one dosage form to the other, so you can look that stuff up. Very similar side effects to what you see with the other drugs, some GI upset, sedation, ataxia, tremor, all those are pretty common with the antiepileptics. But some other things you can see can include weight gain, pancreatitis, so this is one of the kind of drug-induced causes of pancreatitis you can see, and this can also have some nasty effects on the liver, so you want to monitor your liver function test, baseline and follow-up, and then you can look for things like thrombocytopenia as well. Okay, so more monitoring with this one, but it's a pretty effective drug for treating those seizures. Because of the thrombocytopenia you can potentially see, some interaction with drugs that can inhibit platelet function, so be aware of that. Maybe some increased risk for bruising or bleeding. And this one can inhibit CYP2C9 and also this other enzyme system called UGT, which will be important when we talk about lamotrigine, which is another antiepileptic. So we'll talk about that one in just a little bit, but just keep this interaction in mind as we go forward. The therapeutic range for this one, you'll see is pretty soft, meaning that I can go well above this and not really see a ton of side effects, and may be beneficial for some patients. So especially for like bipolar disorder, some people will go up to say 50 to 150. Patients even at a level of say 200 are probably not having a ton of side effects. So this one is pretty well tolerated for the most part, but just be aware this is kind of the normal therapeutic range, but patients can certainly live outside of this to some degree. Next, we have our benzodiazepines. Refer back to your behavioral section for more information on these. Here are the most common ones you're going to see being used for seizures. You have diazepam. This one is either given, say, IV, or we also have the rectal gel. It's available to give, or known as Diastat. So if you ever see Diastat being used, that's the rectal formulation. So again, that's nice if you have patients who are in the out-of-hospital setting and they have an acute seizure. Obviously, patients are not giving this themselves because they're having a seizure, so it's important to make sure you're educating whoever their caregiver might be on how to administer this, right? So obviously this is used for a good long time because this is the most effective way we had to get benzodiazepines into the system, right? Because are you able to give oral medications while they're having a seizure? Probably not. Might take your finger off or something. Might choke on it. So lots of problems with that. So the rectal administration was probably the easiest way to give it for a good long time. Nowadays, what we're actually seeing more of is going to be intranasal administration of midazolam or Versed. So some of our neurologists are actually giving prescriptions for vials of Versed that the patients will actually draw up, or the caregivers will draw up and give with an atomizer. Essentially, it is a device that just kind of makes a fine mist out of the drug. So you drop a normal IV syringe, put this atomizer on it, and you can insert it into their nostril and just kind of split the dose between the nostrils. And that can be another effective way to get the patient the drugs without having to worry about taking their pants off and trying to administer this drug rectally, which can be kind of difficult to do depending on the patient's moving around a lot and things like that. So that's one thing you may see more frequently being prescribed for some of these patients. The other big one to use is lorazepam. That is the kind of most frequently used IV benzodiazepine for acute seizures. This one is nice, even though it's more water soluble. Right, we talked about some of these drugs being more fat soluble versus water soluble. Lorazepam is more water soluble, so it takes time to get into the CNS. But once it's there, it likes to stick around for longer. So you actually see decreased recurrence of seizures with lorazepam on board, which is why we like to go for this one most frequently. Can be given orally, obviously, for acute seizures. IV is going to be the route to use. And actually what we're seeing as well within the kind of pre-hospital setting, we're actually seeing IM Versed getting used more frequently there as well, because again, trying to get an IV on a patient who is actively seizing can be very difficult. So intramuscular administration of these drugs can be used as well. So Versed is probably the most common one used in that route. Some other ones you'll see being used for more chronic maintenance of seizures is going to include things like clonazepam or Klonopin, and then you can also have clobazam or Onfi. This is actually a newer benzodiazepine. All of these are going to be C4 agents, right? So there is some abuse potential associated with them. So they are controlled substances. Okay. We'll talk more about these a little bit when we get to the status epilepticus section, how to manage that. But for acute seizures, these are your go-to drugs in order to treat those. With the pharmacokinetics, remember, we like water-soluble drugs for this case. Something like diazepam is pretty fat-soluble, so it doesn't have a long duration of effect, but the fact that it was able to be given rectally for such a long time was useful in those pre-hospital settings. Again, these are the go-to agents, first line for acute seizures. Then moving on, we then have our barbiturates. So we have phenobarbital or luminol is probably the most common barbiturate we see being used for treatment of seizures. Instead of just working on those benzodiazepine sites, because the benzodiazepines are going to go and bind to that benzodiazepine site, allow GABA to bind better to that receptor to open it up. Phenobarb can actually have some direct activity to open up that channel itself, right? So because it can work more directly, you're going to see more CNS depression associated with the barbiturates than you are going to see with the benzodiazepines. Benzos are very, very safe for the most part when they're used by themselves. You don't see a lot of respiratory depression or hypotension, but you see more of that with the barbiturates. So these have a little bit worse side effect profile than you see with the benzos. These are going to be the drug of choice for neonatal seizures, so you can see that being used frequently for newborns, so that can be used there. And for the most part is pretty effective for generalized seizures. The only problem with it, especially for chronic management, is that the adverse effects kind of limit this. So especially you have a kid in school, memory problems can be a big issue with this one just because it is so sedating. They can be problematic. But if you have a kid who say has issues where they have like severe MR or cerebral palsy, things like that, where they may not be in a normal kind of school setting and they have very difficult to treat seizures, this might be a good option for them, And so those really difficult to control patients, you may see them being on phenobarb at very, very high levels in order to help control that, and they kind of get used to those CNS depressant effects over time. So tolerance can develop to some of these side effects, and so we'll talk about the normal level for this, but I see kids at normally 2-3 times the level at phenobarbital, and they're totally fine. They can have conversations, and they're doing just great. So be aware of that as well. And again, this is a controlled substance due to some abuse potential. This one will also have some CYP induction to worry about. So we worry about inducing CYP2C9, 3A4, so those are important drug interactions to be looking out for. And you will see some renal elimination. So for some kids, some patients, this could be an issue if they have renal impairment. Usually, like I mentioned, due to the CNS effects, you're going to see this being used as kind of more for refractory patients. That therapeutic range is normally, say, 15 to 40. But like I said, I've seen kids at 75, 80, 100, and that's just the level they live at, and they're totally fine. So that range can be a little bit soft. Another drug you'll sometimes use is pentobarbital or Nembutal. This is more used for severe cases of, say, status epilepticus, or if you have, say, significant cerebral edema secondary to, say, trauma or something like that. This is a drug you can use to put patients into a pentobarb coma, is what we call it. So essentially, if you just need the patient to be completely and utterly comatose, this is the drug to do it. So this is a very good one for that. Obviously, you have to intubate the patient. Normally with acute seizures, you may or may not need to intubate them depending on how much meds they get and how well they can protect their airway. But this one, if you are given pentobarb, you're going to have to intubate them to protect their airway for them. So not used very frequently, but every once in a while you may see it being used. Okay, so that kind of covers the majority of kind of the older agents and the ones that are probably used the most frequently. Obviously, if I talk more about one agent, I'm probably going to ask more questions about that. So some of these ones that are kind of niche products, I might not be spending as much time on. I might not ask as many questions about, but they can still come up. So just be aware of that. So if I talk about like pharmacokinetics of phenytoin for 20 minutes, like it's probably more important than, more likely to come up than some other things, right? Okay, so felbamate is one that is used pretty sparingly, can enhance some of the activities of GABA, will inhibit NMDA receptors as well, so kind of multiple mechanisms there, but doesn't get used very frequently, really only for refractory patients due to this risk of aplastic anemia and due to several other drug interactions and hepatotoxicity. So really reserved for a very small subset of patients who failed kind of everything else. You have ethosuximide. This one is important because this is the treatment of choice for absence seizures. So if you had a patient with an absence seizure, a lot of other drugs are not going to work specifically for that. And you guys know what an absence seizure is? What is that? I just had one. Right. So basically that's what it looks like. Basically just kind of like shut off for a few seconds or minutes, and then they come right back. So treat it a little bit differently, and so ethosuximide is going to be the go-to drug for that particular type of seizure. This one is also going to be just a pure calcium channel antagonist. So again, because that's a little bit different mechanism, that's probably why it works specifically for those seizures. Pretty few adverse drug effects for the most part, maybe some nausea, vomiting, but pretty well tolerated for those patients. Next, we have talked about gabapentin and pregabalin previously. Even though they're structurally very similar to GABA, they don't activate those channels the same way that GABA does. But they may help with some interactions with calcium channels and may help to enhance GABA synthesis as well. So it can be useful for that. Where else do you frequently see these drugs being used for? Yeah, fibromyalgia, other like kind of neuropathic pain. So you probably see these being used much more frequently for that than you do for seizures specifically. But they originally got their start as antiepileptics. Do you know which one of these is a controlled substance? So the pregabalin is actually like a C5. The gabapentin itself is not controlled. And again, all that was related back to there was some random clinical study where someone reported euphoria. So they're like, okay, that must be abuse, risk for abuse. So let's go ahead and make that a controlled substance. So you don't see a whole lot of people abusing pregabalin necessarily.
It's got the exact same brand name?
They do not. That was a typo that I just now noticed. Thank you for pointing that out. Pregabalin is Lyrica.
Okay.
Lyrica. That was a good catch. Yeah. So Lyrica so again, the pregabalin is just a little bit more potent. So if you're looking at like kind of comparative doses, you may see like 50 milligrams of pregabalin compared to like 300 of gabapentin. Like gabapentin doses get really kind of ridiculous. You can give grams of the drug versus like pregabalin's like 75, maybe 150 in some patients. So just a more potent version of it essentially. But main adverse effects are going to be the CNS depression, right? Next, we have lamotrigine. This one does get some use. I see this a little bit in some bipolar patients. Certainly is a good seizure medication as well. This one is working to inhibit sodium channels, but can also have some glutamate antagonism as well. So it inhibits the release of glutamate, so antagonizes that in that way. This is important because this one oftentimes is kind of an adjuvant kind of medication, or something that gets added on as a secondary med. You don't see patients frequently treated with this by themselves for seizures. So it's very important to monitor for drug interactions with this one because one of the big risks you run into is going to be rash and Stevens-Johnson's. Bless you. This is more common with this medication than you see with some of the other ones. So big risk. So for instance, if I had an inhibitor of these enzymes, so say something like valproic acid, or to inhibit metabolism of lamotrigine, and I add that drug on, levels are going to be higher, and you're more likely to see toxicity with that. So be very careful with adding this drug on because of the dermatologic reactions. Again, other side effects are pretty similar to the other antiepileptics. For example, there's like specific dosing recommendations if you have a CYP inducer versus an inhibitor on board. So for instance, if I had, say, valproic acid on board beforehand, I was adding on lamotrigine, I use half the lamotrigine dose, just basically half it. In some cases, you may double the dose if you had an enzyme inducer on board. So check your interactions before adding on new meds like this. Again, don't memorize these doses specifically, just know the principle behind it and why we would adjust the dose accordingly. The next one, this is a kind of up-and-comer as far as antiepileptics goes. This is levetiracetam or Keppra. This one is kind of being used for just about everything. I see a lot of patients being put on this one because it is very, very well tolerated. You can basically spray someone down a whole vat of Keppra and they're not going to really have a whole lot of adverse reactions to it, which is nice. Don't know the full mechanism of it. Probably inhibits some calcium channels, but it's probably got lots of other activity there as well. But it's quickly becoming first-line therapy, especially when we had that Fosphenytoin recall. Instead of using phenytoin, we would give IV Keppra instead, and patients tolerated that very well. A lot of our neurologists are starting kids off on Keppra as first-line therapy because there's no real drug interactions. There's no CYP inhibition or CYP induction you have to worry about, and they really tolerate it very well for the most part. So this is becoming much more frequently used, mainly renally eliminated, so it could be problematic for some patients with renal dysfunction. And one of the unique side effects you see with this one is this kind of increased aggression, especially seen in children. So it could be something you see where, you know, if you prescribe it and mom's like, I don't know, Johnny's just not acting right. He's acting kind of extra, you know, kind of being a jerk to his brother. Like, you know, it could be related to this medication. So just be aware of the kind of behavioral changes you can see there.
We talk a lot about renal elimination and its potential complications. Is it more of the fact that it's going to build up to high levels, or is it like further damage to the kidneys?
In a lot of cases, just higher levels of the drug.
So in those cases, we would just give less?
Yeah, so you just adjust it down. But again, you will see that, so say for instance, like, you know, normal starting dose for this drug, let's say, you know, 10 milligrams per kilo, you don't normally give it like twice a day, right? So they get like 20 milligrams per kilo per day. Some patients will be on 50, 60, 70, 100. So even if they did have some renal impairment, like, they can have pretty high levels of this drug and not really see any problems with it. But it's just something to consider. Like if you're seeing increased side effects, increased, you know, sedation associated with it, maybe the renal function is to blame, right? So, good question. Tiagamine or Gabatril is working by blocking that reuptake of GABA, so it increases those levels within the CNS there. Usually used second line, usually adjunctive therapy, so being added on to other things. This one can actually cause psychosis, so it's one of those kind of unique behavioral side effects there. And this one actually they recommend taking it with food because that will slow the absorption down. So you actually don't see as high a peaks of the drug levels. It kind of has a much more kind of nice kind of gradual onset and offset from that standpoint. So one of the kind of unique food-drug interactions you actually want to take advantage of. You have Topiramate or Topamax. Does anyone know where else you might see Topamax being used?
Migraines.
Migraines, yep, so it can be used for migraine prevention. Anywhere else? Some people would actually use it for weight loss for a time. There's actually some better drugs for that nowadays. But yeah, so there's some mild weight loss associated with this one, so you might see it being used for non-seizure purposes. But this one, it has several activities. It is blocking sodium channels, enhances GABA activity, and then also will antagonize some glutamate receptors as well. So kind of multiple mechanisms there. It also has some mild carbonic anhydrase activity, so you can actually see a mild acidosis with this as well, which can, we already mentioned, be useful for helping to increase that threshold for having a seizure. This one can have pretty significant renal elimination, so watch for patients to have have some impairment there because you have levels build up. Probably impaired concentration, the most common adverse effect, you know, some mild sedation and whatnot, but really well tolerated for the most part. But because we are changing pH of the blood and also affecting pH within the urine, because imagine, what are we doing to the pH of the urine?
Are you acidifying it?
Not acidifying, because we have a carbonic anhydrase inhibitor. What does that do in the kidneys?
Picking up.
It's more bicarbonate.
You actually pee out more bicarb, which is why you're getting acidotic. So you can actually precipitate some of these renal calculi. So if you have a patient who have a history of that, that can make that more likely to precipitate. So just be careful with that. Yes.
Does that make you more likely to get infections or anything like that?
I don't necessarily see increased risk of infection, but I mean, if they have a stone, then that may predispose them to have the infection. Yeah. There's zonisamide or zonogran. This one is inhibiting calcium channels, may also affect some sodium channels as well. Again, not used first line, usually used as an add-on medication. This one is interesting because it has a sulfa moiety on it, so it may have some cross-reactivity with that sulfa allergy, so be careful with that. And can also has some carbonic anhydrase inhibiting activity, so you can see renal calculi develop there as well, similar to Topamax. Okay, so some newer agents you might see being used out there, because again, when patients are refractory to lots of other things, we try to throw them on the new hotness and see how they respond to that, right? So we'll see how they can respond to these drugs. So we have lacosamide or Vimpat. I've seen several pediatric patients being put on this. This one is starting to target kind of new sites of action. So while it does block some sodium channels, you'll also see it binding to and inhibiting this collapse in response mediator protein, or the CRMP. Kind of limited information with a lot of these newer drugs, because again, we've had clinical trials with them, but we mentioned how big are like stage 3 clinical trials?
Big, like thousands of people.
Like thousands of people, not millions of people, right? So you don't notice a lot of the side effects you might see when you give it to millions of people. And again, this is kind of more for a niche condition. It's not like hypertension or dyslipidemia, where a lot of people have it. So we don't have a ton of information for things like kind of one-off side effects, but just be aware. You can see kind of common side effects there, very similar to what we've seen previously. And you can also see renal elimination with this. Potentially some patients have even had hemodialysis to pull this off. Not done super frequently, but it can be useful as an adjunctive kind of medication to some of these other drugs. This one is a C5, so it is a controlled substance as well. I'm not going to ask you on the test whether, which of these drugs is a C4 or C5. I only kind of mentioned it just for your kind of information. Is rufinamide or Banzel. This one is actually a derivative of triazoles, which are commonly seen antifungal agents. So kind of derivative there. Some of the common adverse effects you can see here, but the one thing to note is the suicidal behavior. So there's probably going to be a black box warning on that one for that. So just be aware of any changes. They start to have any suicidal thoughts or things like that. You want to make sure, and especially if they have any kind of pre-existing psychiatric history, this might be a drug to avoid for those patients. There's ezogabine or Potiga. This one is actually working by opening some of these potassium channels, so maybe allowing potassium efflux out of the cell can actually hyperpolarize it, make it less likely to have an action potential. This one you can see some QT prolongation and dysrhythmia, so it's kind of one of the unique side effects associated with that. There's perampanel or Fycompa. This one is actually a non-competitive AMPA antagonist. It actually binds to a different site on the AMPA receptor to inhibit the activity of glutamate. Relatively new drug, so just back in 2012, comparatively speaking. And then there are some black box warnings for this one. So psychiatric or behavioral reactions are kind of the most common ones you see there. So you can see aggression, hostility, homicidal ideation. So don't give this to my wife. It'd be bad. Yeah, listen, I say some dumb stuff sometimes. You guys know.
It's not like you don't deserve it.
Yeah, it's not like I don't deserve it. I'm just saying, don't give her any additional. I make her listen to it every single night. It's hence the homicidal ideation. Yeah. So anywho, status epilepticus treatment. So how do you manage these patients who are having status epilepticus, right? And we said, what's kind of the definition for status?
Don't come out of it.
Yeah, they don't come back to their baseline mental status before they have another seizure, right? So that's kind of the big thing there. Immediate care, obviously you want to check your ABCs, make sure they have their airway clear, make sure they are breathing appropriately, have circulation. Obviously, depending on whether you're in hospital or out of hospital, you need to protect the patient from injury. So again, do not restrain, remove dangerous objects away from them. You'll see that the first line therapy are going to be our benzodiazepines. Right, so again, out of hospital care, usually Diastat is going to be the big one. So diazepam, rectal administration. Again, when you are, say, a parent and your child's seizing, you're probably pretty freaked out unless they've had a ton of seizures and you're kind of used to it. So patient education on how to use the Diastat is really important. One, make sure they are applying the lubricant to the product before inserting. That's important. The second thing is make sure they're inserting it far enough into the rectum to actually make sure that the drug is getting to a place where it can be absorbed, and make sure they are kind of, once they remove it, kind of hold the cheeks together to make sure that the drug stays in place, right? So it doesn't accidentally get shot back out. So they're kind of the three big things to make sure that the patient absorbs it well and they're actually getting the full dose, okay? Other things you can see is that intranasal midazolam can be useful either via EMS if they don't have IVs, or just sent home with the patient can be useful. And then lorazepam is going to be your go-to IV agent. Lorazepam has some issues where you don't really want to give it IM because of the fact that it doesn't like to go in solution very well. Kind of similar to phenytoin, just not to as big of a degree. Can cause some tissue injury. Usually if patients are not responding to, say, several doses of benzos, so say we give them 2 or 3 doses, they're still seizing, then we can start to move on to other agents. This is where things like phenytoin or fosphenytoin are probably most commonly being used. This is kind of your go-to second-line drug for status. For some patients, especially, try to do a good history to figure out what they've been on previously. Try to figure out kind of what's going on with them to where, if they were on Keppra previously and say they missed their last couple of doses, well, maybe phenytoin is not the good drug to load them with. Maybe I should go with Keppra instead. Okay, so Keppra can be another good IV agent. Valproic acid is another one you can give IV as well. So try to get that history to figure out what's going on. Very frequently, especially at Nemours, we have a large group of patients who are coming in from out of town, out of country in a lot of cases, and especially like Make-A-Wish trips and stuff like that. And so they come here to go to Disney World. They get stressed out. They're around a whole lot of new kind of environments and things like that. And what happens? They seize, right? So they end up coming to us, and so we have to kind of figure out, okay, what meds were you on previously? What kind of doses were you getting of these? When's the last time you took your doses? Say they left it at home on accident and they couldn't get a new prescription, like that could be a precipitating cause for some of this. So try to figure out what the history is before choosing which drug to go down to next if you can. Other agents you can potentially use, phenobarb might be a good option for some of these patients as well to put them down and stop that seizure. But again, with phenobarb, we're going to see more things like respiratory depression, hypotension, so this is going to make things like having to intubate much more likely, right? And again, just keep going down secondary agents until you kind of get the seizure stopped. In some cases, if you kind of failed 2 or 3 different therapies, you may need to consider things like general anesthesia, pentobarbital coma, propofol, which is something we'll talk about in the surgery section, is a good drug for this as well. So kind of just putting them down completely as best you can is one way to do it. And then at that point, you're checking the EEG to make sure they're not in some kind of like non-convulsive kind of status epilepticus, because that can be problematic. So a good example of this would be a patient I had. She was probably 93 or 4, something like that. Little old tiny lady who'd been on theophylline for her COPD, and she had never had her dose adjusted. So she's in this nursing home, never had her dose adjusted, got dehydrated. Sure enough, levels shoot up, right? And so we mentioned methylxanthines being a possible cause for drug-induced seizures. So of course she comes in seizing. Theophylline is very difficult to control seizures as far as drug-induced ones go. So we end up hitting her with 3 or 4 doses of benzodiazepines, still seizing. So go ahead and go with load her with phenytoin, even though phenytoin doesn't really work for drug-induced seizures, but we were kind of at a loss at that point. So we tried that, still nothing, and eventually we were able to get her down with propofol. So we were able to give her propofol, stop seizing, but then we got the EEG, and sure enough, you just look at it, it's still obviously having seizures. So consider that non-convulsive status epilepticus is a possible thing that's still going on, because the physical manifestations may not really give you the full story, right? Especially for those of you guys that might know, when you intubate a patient, what kind of drugs are you giving them when you do that? Heard of paralytic, right? So you give them a paralytic, what is that going to do to a seizing patient? If I paralyze you, you can prevent all your muscles from doing anything.
Your brain is still firing.
Yeah, it's going to look like they're not seizing anymore, but their brain is still firing off, right? Still it's getting fried. So that's one of the things you have to consider is like, well, what kind of paralytic did they get? Did they get a short-acting one where it's going to wear off pretty quickly and we can see if they have another seizure? Or is it one thing, it can be something where it lasts a lot longer and they could be seizing, we don't know it. You have to consider things like bedside EEGs to kind of determine what their seizure status is. So kind of interesting when you kind of work with these patients. It can be kind of difficult to manage in a lot of cases, but it's important to try to get as best a history you can and just kind of go down that algorithm of trying, okay, this drug didn't work, let's try a different class of medication, let's try a different one, and then finally just, completely just put them out totally. So any questions on that? All right. So if you have to change an anti-epileptic drug, so say a patient was having kind of intolerable side effects or the drug was just not really working for them, you generally can switch over to a different type of drug. Most often you're going to switch over to a different mechanism. So for instance, if I was on phenytoin and that really wasn't working for me, would it make sense to go to carbamazepine? Probably not, right? It's another sodium channel blocker. Maybe something like valproic acid might be a better option in that case, or something like levetiracetam or Keppra would be a better option there. So the idea when you're switching these drugs is to try to avoid toxicity from having both of the drugs on board, but also avoid any breakthrough seizures. So frequently you end up having kind of titrate down on one drug while you're kind of starting up the other one as you kind of gently titrate that dose up. That will help to kind of avoid some of those toxicities and hopefully avoid any breakthrough seizures. As far as stopping anti-epileptic therapy, typically they need to be seizure-free for 2 to 5 years on anti-epileptic drugs. Only have a single seizure type. And then if they have a normal neurologic exam, so again, if they have like no structural reasons for the seizures, and they have a normalized EEG, that may be a good cause for them to kind of try titrating down off of the drugs, and then see if they have recurrent seizures at that point. Okay. Some patients may need lifelong therapy, others may not. So it's going to be on a patient-by-patient basis. So looking at drug levels, again, why would you check a level for a patient? For some reasons. Yeah, so if they're having side effects, would be good reasons. We want to see if their levels are too high, and that's what's causing the side effects. What other things?
Still seizing.
They're still seizing, so if they're having not enough efficacy, we can see if their levels are too low. Any other reasons? Okay, so if you suspect they might not be clearing the drug appropriately, so if they have a change in renal or hepatic function, that could be a reason, yeah. So again, have a reason for checking a level, because again, if you check a level for no good reason, and it comes back abnormal, you need to address it, right? So it may lead you to have to do things you don't necessarily, wouldn't have done in the first place. So try to have a reason before you're checking a level. So it could be efficacy, could be for safety or adverse drug reaction reasons. But when you're assessing drug levels, make sure you're at steady state first, right? Because if I say start a patient on a drug and I check it before steady state, what might that lead me to do? It might lead you to increase your dose before it's really had a chance to reach steady state, right? So then, of course, it will raise my steady state even further. So check drugs after they've hit steady state. Assess for possible drug interactions. So especially, things like valproic acid and lamotrigine, or if I were to add, an inducer like phenytoin and then carbamazepine together, like both of those can induce 3 or 4. So consider drug interactions there. And then other disease states. So if I had like changes in clearance or something, that would be another reason why we might want to check our levels there. Obviously, treat the patient, not the level. So again, if your patient is totally fine, they're having no seizures, no side effects, the level's low or high, it's probably fine. Just leave it alone, right? But if they're obviously having toxicity and the level's normal, that may not be normal for them, right? They may be more sensitive to certain side effects, or they may need higher levels than what would be considered normal for other patients. So always consider that. Treat the patient first. We mentioned adverse drug effects being kind of, or CNS depression being the main adverse effect with kind of all of these anti-epileptic drugs. Keep in mind that this can range anywhere from mild drowsiness all the way up to drug-induced seizures, especially when you have overdoses or if you had kind of drug interactions you did not account for. So be aware of that. Probably see valproic acid and lamotrigine causing kind of the least amount of CNS depression, so there might be better options to go with for some patients. And like I mentioned, phenobarb can be a problem, especially for like school-age kids, especially with memory impairment and things like that. So it may not be best used for those patients. So that's why again we use it for like neonatal patients or neonatal seizures. It's good for that age group. As I mentioned, the behavioral side effects you saw with Keppra, so that can be seen, a little over 10% of those pediatric patients. So be aware of that. Make sure to kind of assess for any changes. Talk to family members who may be noticing something that's happening with the child. And just be aware that some of the other ones, cause psychosis, depression, confusion. So lots of different adverse effects to be watching out for with these drugs. Mentioned dermatologic reactions. These are probably going to be most pronounced with lamotrigine, but certainly other things like carbamazepine, phenytoin, sometimes phenobarb can be associated with this as well, especially if you combine the medications, or especially if you're not assessing for the drug interactions or the levels of them are going higher. That could also lead to these manifestations. So be aware of that. Make sure they have a good education on if you see any change, any worsening rashes, or if you see any blisters, things like that. Stop the drug, come in and get evaluated. Mentioned some of the hematologic toxicities you can see here. Most often, it's going to be some mild thrombocytopenia, maybe some leukopenia. Probably going to be seen more with carbamazepine, valproic acid. When I say high dantoins, that is just referring back to phenytoin and fosphenytoin. So it's probably the most common ones you see there. Obviously, if they're having any kind of bone marrow suppression, look for things like sore throat, mouth ulcers. That can all be signs of toxicity there. So again, it could lead you to want to go ahead and check a CBC to make sure nothing's going on. And then we mentioned some of these drugs, especially the ones that are heavily metabolized within the liver, can cause hepatotoxicity. So probably carbamazepine, valproic acid, and phenytoin are probably going to be the most common ones associated with this. And so, especially with valproic acid, this is going to be most likely to occur usually in the first 6 months of treatment. And it could occur more commonly in children, so just be aware of that, especially if they're under the age of 2 and they have multiple drugs on board. This increases your risk for hepatotoxicity. Mentioned sedation. Again, if you are having patients who are having kind of unacceptable sedation associated with these meds, then always consider either adjusting your dose, again, making sure to kind of balance the sedation versus the efficacy for treating the seizures. You may look at changing the dosing schedules, maybe kind of focusing more of those meds maybe towards the nighttime, where they are going to be sleeping anyway. If you can try to scale back therapy to just one drug, that can be useful. And then potentially switching over to a less sedating antiepileptic drug could be good for them as well. In monitoring, you're looking for seizure control, other adverse reactions the patient or caregivers might be reporting, drug levels if they're applicable, and again that only apply to a few drugs that we mentioned there, and then the labs if we need to. So again, looking for things like sodium with what drug? Yeah, the ones that cause SIADH, which is carbamazepine, Oxcarbazepine. You check sodium with them. You check your LFTs with valproic acid. So just keep those kind of labs in mind. And mentioned therapeutic drug monitoring only for the ones we mentioned levels for. I will certainly see, especially for patients who are taking their drugs like they're supposed to, or saying they have compliance and are still having failure of therapy, I will see some neurologists go ahead and order levels for drugs that we don't normally get. So for instance, I've seen them order Keppra levels, I've seen them order Lamictal levels. The problem is there's not really well-established therapeutic ranges for those drugs, so you get a level back, and you can't really correlate it to much, right? So you can't say like a therapeutic range is say 10 to 20, So could be a limited use utility, but usually those are going to be sent out to take several days for it to come back with any values. And as I mentioned, the drug interactions are going to be the biggest thing here, so always double check your interactions. Be aware of things like your CYP inducers like phenytoin, carbamazepine, CYP inhibitors. Just do an interaction checker before prescribing one of these drugs just to look for anything that could be there, right? And when I say interaction checkers, you know what I'm referring to? Like usually whatever institution you work at will generally have a drug reference of choice, so whether it be Lexicomp or Micromedics or something like that, they always have an interaction module where you can basically just type in all the patient's meds, just type them all in, hit enter, and it pops up with every single drug interaction they have. Sometimes it can be kind of debilitating to see how many drug interactions actually pop up. Look for ones that are like red or say X. Like those are the big ones to watch out for because those are probably going to be dangerous for your patient. If it's like may cause increased sedation, like okay, well you can work around that. But if it's like will kill your patient, that's the one to watch out for. Yes.
Do you know if our school has one that we can use on verification?
Yes, you guys have so much access to great stuff. You guys don't even know. You guys have access to clinical pharmacology at the very least. So if you go to the library website, if you go to databases, I like clinical pharmacology. They have a very good kind of almost like a narrative kind of structure for how they describe their meds. Like some places are very clinical and they say block sodium channels. Like this website will give you a little bit more kind of narrative into okay, well based on these trials we saw that it blocks these sodium channels and it causes blah blah blah. Maybe too much information in some cases, but they have a good interaction checker on that. So clinical pharmacology is a good one. I don't know if you guys have access to Micromedics, but that could be another good one to check out. That's usually the one they go to, and then Lexicomp. That's usually through UpToDate. So I know you guys have access to UpToDate, so check for Lexicomp as well. Those are the other good ones. So I use Lexicomp probably most commonly just because that's what the Moores has, and that's what I have licenses for. So anyway, yeah. So any of those will have a just fine interaction checker, so you can put all that stuff in and kind of pop up and see if they have any issues there. Good. Beware of oral contraceptives interacting with some of these antiepileptics. Those that can induce those CYP enzymes can also increase metabolism of the oral contraceptives. So that includes, phenytoin, phenobarb, carbamazepine. They can all induce those enzymes, making the oral contraceptives less effective because they're getting metabolizing more. Lots of ones that do not interact with them. So again, just check your interaction checker to look for that. See what's going on there. Oh, I had a good case the other day. I was working in the ED Friday, and we had a patient who came in, and the ED attendant called me up and said, "Hey, got this girl. She's come in. She was being put on orthotricycline low for her dysmenorrhea. She's having some breakthrough bleeding." And this is kind of an old school guy, and he's like, "And I think I missed that lecture in med school on oral contraceptives, so I need you to help me pick a different one to put her on." So, what do you think? Kind of questions did I ask?
Her on the meds.
Yeah, okay, when is she bleeding in regard to the pack, right? So I said, was this in the beginning of the cycle? Was it towards the end of the cycle? Good. And then I had to figure out, and looking at specifically what product she's actually on. So if you look at the orthotricycline low, that tricycline refers to it being a triphasic birth control. So you would have increasing levels of estrogen as you went through the cycle. So you start lowest at the beginning of the month, and kind of each week you would have increasing levels of estrogen, and then the fourth week you have nothing, right? So it's just all placebo. So this ended up being early on in the pack, as far as he could surmise. So what do you think I recommended? Yeah, so I actually wanted to do something with more estrogen in it, right? So either by giving her a more consistent estrogen level, so using like a biphasic or monophasic one could work, and just increasing level in general. So like for instance, that orthotricycline, I think it went from 15, 20, and 25 micrograms of ethinyl estradiol. And so I ended up recommending Yasmin. Yasmin has that drospirenone, which is, it has that anti-androgen receptor activity. So it's, a lot of females like Yasmin or Yaz the best because it has less androgenic effects and has less kind of fluid retention associated with it. So of course all the nurses in the ED are like, yeah, put her on Yaz. Yaz itself, Yaz the brand name, has less estrogen in it than Yasmin. Yasmin was kind of the first one, so I ended up recommending Yasmin. And so I don't know if she got any better, but obviously it takes time to kind of assess for that. But stuff in pharmacology actually comes up in the real world, is the point. So be aware of that. Okay. Yeah, almost. Okay, so any questions on the antiepileptics? Also had a good case that came up. We'll talk about that when we get to the headache section. But have you guys covered ergotamines or DHE for headaches yet with Professor Sousa?
We talked about it.
Yeah, so I'll have a good one we'll talk about there when we get to the headache section, probably on next Tuesday. But if no other questions, I will see you guys Thursday.